everybody. I'm Dr. Louise Tofts, Paediatric Rehabilitation Specialist and Paediatrician, and I'm delighted to chair this session focused on Ehlers-Danlos syndrome and hypermobility spectrum disorder in children, particularly in younger adolescents. We will start with a presentation to provide some background, followed by a case-based discussion between the group, which is a multidisciplinary panel. Welcome all my colleagues. Then we'll do a Q&A for you guys. I'm pleased to welcome Nicole Pates, paediatric physiotherapist from Perth, to start the session.
Thank you, Louise. So I'm Nicole Pates, a paediatric physio, and I'm going to kick off session 3 by exactly what you said, Louise, discussing the impact of EDS and HSD on young children and young people. And following my presentation, we're going to welcome these lovely members of our panel, Dr. Louise Tofts, Elizabeth Hornsby, Michelle O'Sullivan, Cheree Sheldon, and Katie Cleary. During this, you've just said all of this, Louise, so we'll move on through to the slides now. We will conclude at the end of our panel with a Q&A, and we're all really excited to understand what your questions are, and hopefully we can answer them to the best of our ability, just remembering that even though we're health professionals, we can only give generalised advice. We can't give individualised advice in this forum. Great. How do I? Okay, so this is what it looks like. So I'm going to start off by talking about the new diagnostic criteria. In 2023, a group of experts from the Paediatric Working Group of the International Consortium of the Ehlers-Danlos Syndrome and Hypermobility Spectrum Disorders created a diagnostic framework for children. And it can be used from people as young as 5 years old all the way through to biological maturity. We talk about biological maturity being the end of puberty and the end of bone growth, or the age of 18, whichever comes first. And listening to this morning's sessions, I understand that getting a diagnosis is really important to you guys. And this criteria might be challenging in the sense that Ehlers-Danlos syndrome isn't a diagnosis within this framework. So I want to talk to you guys a little bit about why and what that actually means, because some people think, it just means we'll do nothing, and it's not that. I promise you that. So why did this change occur? Well, we were using, before 2023, the 2017 diagnostic criteria, and that was developed for adults. And I'm pretty sure you know this, but children are not adults, and they are changing constantly over time, not just in their physical systems and their bony morphology and their height and their everything, but also in their brain development, their gastrointestinal respiratory systems. Everything is changing and growing. And there are diagnostic challenges unique to our kids, especially our youngest kids. Kids are typically flexible and they stiffen up with time. And some skin changes develop over time. And really, we have to understand that they're growing and changing, their skeletal proportions are changing. And so sometimes what we were seeing was a misdiagnosis. I've seen a couple of kids that were diagnosed with EDS but have rare genetic syndromes with other potential significant cardiovascular complications that should have been picked up earlier and different things like that. But we're also seeing underdiagnosis and dismissal of kids that really need help. And so we're trying to create a tool that allows us to understand where a child is at in time and what's happening for that family and provide the right support at the right time. So this is really cool data. The first graph on your left is representing cross-sectional data, which means that we're checking in, we're looking at different stages of time, but it's not a longitudinal, so we're not following the same people over time. So we can't infer cause, we can only look at associations. But you can see that in this Australian population data, we get less flexible as we age. Well, some people do, and some people stay flexible. And on the right-hand side, you see a graph. This is unpublished data by Verity Pacey's group. You can see that for children going through puberty, they tend to stiffen over time. So their Baton score reduces over time by 1 point over that 3 years period. And that's just important to understand. But what is normal in terms of flexibility for kids? That's a really important question. Like, you guys, as adults, we have clear understanding of population data and cutoffs, but for our kids that are growing and changing, what's normal? We use the Baton score to understand what is happening in kids' joints, so how flexible they are, but you know here in the room that the Baton score is just a screener. It's not all the joints, it's out of 9, but it's really easy to administer. And we have now got really good reference data for kids over 5 to show us what is normal. So Louise's group and Kylie Williams presented their research in this year. Actually, it was released, and what they did is they looked at lots of kids and they measured their flexibility and on their Baton score, and they plotted out all those data points. And they came up with what's the middle, and then we looked at the variance, so the spread, and they found that for kids with 6 or more out of 9 on the Baton score, they sat in that top 5%, or 6% for boys and 13% of girls, up at that top end. So that's showing us that these guys are outside of what we call that normal variance. They're sitting at the top end of the spectrum. And it's really tricky because we need more kids in that study, and we need to look at it further, because potentially for girls and for younger children, it might be more appropriate to say 7 out of 9 or more than 7 out of 9 is generally hypermobile. And so that research is ongoing, and we're really lucky to have some fantastic researchers that are trying to figure out what this is for us, for our kids over time. So the first step is looking at how hypermobile are these kids. We also use, once we've done that screening, we go, 6 or more out of 9 means they're hypermobile. So what do we do next? Well, we might use more in-depth screeners like your lower limb assessment scale or your ULHAT, your upper limb hypermobility assessment tool, to look at what else is going on in all of the joints. So we get a more in-depth analysis of what's happening for your child. Some kids might be really flexible through their ankles, some through their hips, and what else is happening. We see a lot of kids in clinic that have a lot of bend through their ankles, and then they are really struggling to develop that power for running around 4, 5 or 6. And for me, it's trying to look at all of those things together, because if they don't develop that skill of running in that 4 to 6 year critical time period, it's going to be trickier. Like, that's the best time to intervene. So we're looking at all of these things together as physios. But what about 5, under 5? It's so tough. Babies and infants have really soft cartilage, and their bony morphology, the shape of their bones are immature, they're different from us, and they're almost universally hypermobile. Sitting here, having worked in tertiary and community centres, I have a vast spectrum of kids that I have seen across different age groups, and in my head I'm like, that's much more than I've seen. I can think about that, but we don't have population data on that. And so that makes it really tricky, because we don't have a really good tool. I'm going to show you pictures of the hands in a moment. If you look at these hands of a newborn in A down to a toddler in D, like your hand and finger testing isn't testing ligaments, it's looking at their immature bones here. And so that makes it really tricky. Like, what tools do we have? What joints do we need to assess? How can we develop something really robust that's going to give us a really good indication of what's happening for these babies? In saying that, if we had someone like Harvey, Jackie's son, come through with all these systems and all of the different effects that he was having in his skeletal changes, his hip dysplasia and his telopees, he would receive help regardless of his diagnosis, his developmental delay. All those things together would be like, let's help this baby. So what does it mean? Kids change over time, symptoms change over time. What are we going to do? How frequently do we check in on these kids? What this tool does not mean is watch and wait. And I want to reassure you that all the beautiful health professionals in this room, and if you feel like you're being told to watch and wait, you don't have the right health professional, because it doesn't mean watch and wait, it means understand and act. We need to intervene early, and we need to give these kids the best start in life, the best potential start in life. So this is what the new criteria looks like. It's fantastic. You'll see up the top here, it's got the Baton scale, the Baton score out of 9. And some kids might come to us and have a 6 or more out of 9 on that Baton score and not tick any other box. There are some kids, they probably won't come to us, but there are some kids out there who are generally generalised joint hypermobility, but they don't have any symptoms. We just don't see them very much, because why would you go to physio if you didn't need help with anything? But there are those kids that exist, and it's really important that we find them, and in our studies, our research, we know about them, because then we can look at changes over time, and if they do become symptomatic, what are the other things that are happening for them? And it allows us better to understand and have better management strategies and things like that. Does that make sense? So it's really important. But then we have our skin and tissue section, our MUS complications, and our comorbidities, which I'm not going to bore you to death with going through it all, because you've probably seen it. And my brain, I look at it and I'm like, oh my God, there's so many words. So I like to look at the picture because kids can sit in different groups. They can be generally hypermobile and have activity-related pain and some instability, and they might sit up in that top purple section. But then as they hit through puberty, they might develop some dysautonomia and chronic pain and other comorbidities, and then they'll sit between the two in the EDS HSD systemic subtype. And what this tool allows us to do is understand what's happening right there and then for that kid and get the right help for them. And they may move through. It doesn't mean that they're just watch and wait and let go into the system. What you'll notice with this tool is that it looks at a lot of the different systems. So this is some cross-sectional data from a study from Verity Pacey et al. In 2015, and it showed, look at all the systems there that we talk about. So we talk about stress incontinence, diarrhea, constipation, there's gastrointestinal, they're looking at the skin, they're looking at injuries, they're looking at pain. And what it showed is that for children who had increased pain and increased fatigue and stress incontinence, they actually had a lower quality of life, meaning their symptom burden and their disability was higher. But it also showed us that that disability and symptom burden wasn't related to their Baton score, meaning if you had a 9 out of 9, it didn't mean that you would have more worse symptoms than a 6 out of 9. If you're hypermobile, you're above that 6 out of 9. Does that make sense? Yeah. What that research told me as a clinician is that I need to screen all the systems. I need to understand what's happening for that whole child, because just looking at their muscles and their flexibility isn't going to give me the best information to help that family. And so as health professionals, we're really trying to understand the impact of generalised joint hypermobility and the symptoms that your child is experiencing, or that you, as a teen in the audience, may be experiencing. So, these outcome measures are measures that we use in our clinical practice to check with what we're doing is working, to make sure that we are having an impact. And we might do things like the 6-minute walk test, look at how many days off school you've missed. We might do movement proficiency tests, or understand where their motor skills are at compared to other kids their age with the BOT2 or the MABC2. We might look at their handwriting, and they're standardised tests that help us provide evidence to funding bodies that potentially your child is not sitting where their typical peers are and they need more support. So they're important to me as a scientist. But really, I sat down with 11 or 12 kids the other day with chronic pain of varying, some had HSD and some had other things. And they said to me, we hate the VAS. Stop asking me for a number. Why can't I say 6.75? Why can't I say 12? And I was like, oh, and they're like, what is it relevant? I just want you to help me with what I want to do. And I was like, well, I see your point, but also, and so, it's really important to sit down and understand what is important to kids and teens, and what do they want to tell us, and how do they want help. And those kids, out of that session, it came that they wanted us to see me, ask me what I want, ask me what's happening in my life, understand me, help me put it together, and then do what you say you're going to do. They were the 4 points that came out from working with those teens. And that's true. How many times have you been there and someone's like, oh yeah, we'll get that blood test, or we'll do this, and then it never happens. And so it's part of, as a health professional, validating and believing is doing those things, seeing them, asking them, understanding, believing them, and saying you're going to do what you do, doing what you say you're going to do. One of the other measures that we used that was in that that data table is called the PEDS-QL, which is a quality of life tool, and they have different types. They have a fatigue, but they have a general quality of life tool. And I really like this tool and working with parents and their young person that they're looking after, because there's a parent scale and a child scale. And it's very quick, it's one page, and it looks at physical functioning, emotional functioning, social functioning, and school. And I remember sitting down with a 10-year-old, and Mum was like, oh, physically he needs help with this, this, and this. And the kids come back, he's like, I just want help with school and my social stuff. And so like the mismatch, it was a really beautiful bridge of communication to realign priorities and get on the same page. It didn't mean that we didn't address the physical functioning. I mean, I'm a physio, that's what I do. But it allowed that connection and that recalibration together. So if you're a health professional in the room, this is a really lovely tool to use with parents and children or adolescents. And they have different tools for different age groups depending on your child's age, because kids change over time with what they can understand and how they word things. Then we have the Spider, which was developed by Jane Simmons and her teams, which helps us as health professionals understand what's happening for your child. It's beautiful because it has all these domains, which, as Ellen pointed out earlier, there are all these systemic potential effects that can happen and comorbidities. And so not only do we understand what's happening, but it asks you to rate the impact that that area is having on your life, or your child is having on their life. And so, for example, yes, pain and fatigue might be difficult for this child, but if they came in and their Spider showed that anxiety and depression were having the most impact, I'd be working with my psych straight off the back, because even though physical stuff is important to me as a physio, it's not important to that family, well, it's not the priority for that family at the time. And so the Spider and the PEDS-QL can be used to, as clinicians, to test how we're going, because we can use it at the start and we can use it at the end of a treatment block or a management block. And we use the PEDS-QL and the Spider all the time, and it's lovely. I think in one of the programs that we run with our psych and our OT and our physio, we sit down together with the family and we look at everything that's happening and we prioritise and we figure out what we can help with and where we're going to start. And I think now we've got almost 45 data sets that have come through that program, and I think there's on average a 37% improvement in that quality of life. And working together as a team and understanding what's happening for the whole child in the context of their family is really important. And then, as you know, things can get worse, or new things can crop up over time. So understanding why can be important, and sometimes it might not be as relevant, but whenever something new crops up, we always want to understand if that individual's capacity is not meeting their physical and cognitive and social load. So factors that may contribute to new or worsening symptoms are injury, sickness. We talked about long COVID before, COVID before triggering different autoimmune or autoinflammatory responses. Deconditioning, we heard Nick Frost talk about that in terms of that muscular deconditioning around the neck and that worsening that functional instability. We talk about physical activity levels, whether they go ramp right up all of a sudden. I was telling Lou that in WA we had a number of spinal stress reactions come through because these 9-year-olds were being taught back bendovers with no control, and so that was really a difficult situation to manage. But they just ramped up that activity with no control and were just bearing down on their joints. Surgery, growth, bones grow faster than muscles, and if we have a lot of excess mobility that we need to control, whether it be in a straight plane or in rotational planes, we need to be able to control that. Puberty, we're going to talk about that a little bit later, I think, in terms of hormones and the impact, but not just puberty, the cognitive changes that happen through that stage as well are really important. And school transition, major life events, it's always interesting when you look at kids who may be generally hypermobile, that are functioning, they love life and they're running around and they're playing at home, and it's before school. They might be at early childhood education or daycare, we call it in WA, but it's they self-pace. They can choose their activities, they can choose what they want to do, and then going into a formal schooling environment, and that increase in pain or fatigue with the increasing cognitive demands or the social demands, or having to sit still on the mat when you are trying to find out where you are in space. And so school transitions and going into high school, puberty, menarche, all of those things can really impact the worsening or new symptoms. Talking about that school transition and the impact, I think that it's important to flag neurodevelopmental conditions at the moment. And we're going to talk more in depth about these in the panel at the moment. But if you're a health professional in the room and you have a young person presenting with symptoms, I urge you to look beyond just how flexible they are and their joints and look at that whole person and understand the current state of the science for these neurodevelopmental conditions. We don't know the exact link for those kids that are sitting right up here in their Baton score, 2 standard deviations above the mean, in the whole population. But if you're working with a child with developmental delays or potentially these neurodevelopmental conditions and hypermobility, all of these conditions can be diagnosed and managed in their own right. We don't have to find the link between, but we can we've got great tools that we can, or referral pathways that we can refer on and attain diagnoses so that the right management and support can be achieved. So if you're a health professional in this room, please consider these. DCD is a really important one because, the clumsy kid or the lazy kid, I don't think kids are inherently lazy and they're not but is there something more to why they're clumsy? I've got bruises from my clumsiness, maybe I have a bit of DCD, or my cars, it's fun. But kids with DCD, we know that they tend to avoid activity and lead a more sedentary lifestyle than their peers. And that is not great because we know that what inactivity we know if they don't get those fundamental motor skills early, it doesn't have it increases risk factors for things further along the line. And we know that these motor difficulties persist into adolescence and adulthood. Their function might improve, but their motor difficulty remains. And I remember one lecturer saying to me, a kid with DCD is an adult with DCD, and because all 4 corners of their car have dents. Which is probably not a diagnostic tool, but it was a good reminder for me to think about it. But you don't just grow out of DCD. And from the Can Child website, we know that 50% of kids with DCD will also meet the criteria for ADHD. And that's really hard because in the classroom, there's such an overlap between DCD and ADHD, but, the kids with DCD are trying to pay attention. They look restless, but they're trying to figure out where they are in space and coordinate, and they're trying to figure out how to hold that pen and coordinate their body together. They might look restless, whereas in ADHD, it may look the same. And even with kids with pain, they don't want to sit on the mat if they're in pain. They wiggle, whether it's related to their hypermobility or something like an inflammatory condition like juvenile arthritis, autoimmune condition. They won't want to sit on the mat, and let's not label them as naughty and lazy. Let's look at understanding what's happening for that kid and provide some strategies, which we're going to talk about. Putting a lot on my panel here. And the last thing I want to flag in terms of those neurodevelopmental conditions is autism. So 1 out of every 66 children are identified with autism, and that's a stat from Can Child. And this is the diagnostic criteria. This slide is mainly for the health professionals in the room, meaning make sure that you're thinking about it in your assessment of children if they're coming with multiple things happening for them. And not only don't just think about it, but please be neuroaffirming in your practice. If you don't know about neuroaffirming practice, talk to an autistic person, understand their lived experience and what has been helpful and unhelpful, or do some neuroaffirming training. Particularly the one example that always comes to mind with physio is I have a parent of a child and they are autistic and they toe walk, and everyone's trying to correct the toe walking, and that mother thinks that the toe walking is a stim. So I'm not going to correct their toe walking. My job's to protect their movement at their ankle long term, and we can do that many different ways, not taking away the stim. So talk to your families. They understand their child best, and be neuroaffirming in your practice. So these lovely people behind me are amazing, and what they do when they see your child is they consider that whole child and they look at what's happening in their bodies. What are some of those systems that are affected? What do we need to think about when we're working on our management strategies? We don't like to say intervention as much anymore in paediatrics. How is it affecting them in their day-to-day activities, and how is it affecting their participation? Because for kids, it's not that they can't run that bothers them, it's that they can't play with their friends that bothers them. So we run a running group for 8 to 12-year-olds, and they say, there's some research going on at the moment, but one of the main themes that comes out is, I wish I had this sooner. I wish I was able to just do this a little bit better sooner and that I had this, because I just wanted to hang out with my friends at recess and lunch. And then their personal factors and their environmental factors. So that's why it's not a one-size-fits-all approach. What's the capacity of the family? How many kids are in the family? What's that child's own unique personality and strengths? And what are their goals? And so looking at all those things together will help us really support and assist them to the best of our ability. We're going to talk about this in the panel, is supporting their physical, social, academic, emotional and psychological well-being. Because you can't just focus on the physical, or we all work together, and particularly with kids who might not be able to describe what's best happening for them in their life at that point in time. It's sitting with them and understanding and working with that family collaboratively. So thank you for your attention today. I don't know if I waffled too much or made enough sense, but I'm going to hand over to my beautiful panel now, and I can't wait for the questions at the end.
Katie. Hi, so I'm just going to introduce Katie Cleary, paediatric physiotherapist, who's going to present our first entirely fictional case, but based in clinical experience over many years between us all. You got one? Yep.
Okay, all of our disclosures are there, guys. Okay. So Arlie, this is our little friend. So Arlie is a little one who is a very common child that we'd see in clinical practice. So I guess having a little bit of a look through this, as some clinicians out there, you'd probably recognise Arlie in terms of her presentation and her hypermobility and some of the other things that are going on for Arlie. So I'm going to have a little bit of a chat through Arlie, and we're going to talk about how we would manage the care of a little person like this that might be struggling with some of these challenges. So Arlie is an only child, and she lives with her very supportive family. She's very anxious in all settings outside of the home. So she's having a lot of difficulty on the playground. She's unable to climb up the ladder and go down the slide with her friends. She's falling over a lot, which is really common in our little ones with hypermobility. She's having trouble with her sort of fundamental motor skills. So that is things like catching a ball, being able to jump. She's having trouble with some of those new learning tasks, such as holding a pencil and getting a little bit more proficient at those fine motor skills. She's avoiding using bikes and scooters and things that are a bit wobbly and a bit challenging. And so all of these things are really affecting her participation. So if we go back and we put our impairment sort of hat on, and we're looking at the underlying things from when we assess a child like Arlie, she's hypermobile, so really, really high baton. And as Nicole mentioned, that is indicative of that significant hypermobility in that little person. But again, we don't have any normative data in that age, so it is just a sign. The thing we wanted to point out for Arlie is hypertonia. So who here has assessed a child that has presented for hypertonia that turns out to be hypermobile? Yeah. Okay, so I'm going to talk a little bit about hypertonia shortly. So the other thing that's going on for Arlie is she has bilateral foot pronation, so her feet roll in a lot. So she's already wearing orthotics, which for a 4-year-old is it's quite early, and it's probably indicative that there might be something else going on. She's got speech delays, and she's having a lot of trouble with her strength and getting really tired. So I'm going to talk a little bit about developmental delay now in the context of hypermobility. So developmental delay, all kids reach milestones at different ages. So I guess with the physio hat on, we're looking at milestones being sort of like your big fundamental motor skills, such as like running, jumping, standing, walking, crawling, all of those sort of things. But developmental milestones are things like waving, are things like holding a cup and having a drink, are things like saying our first words or communicating. So those milestones are on a big trajectory, and they occur at different times for different children, but we know really robust norms in terms of when those timeframes should be. So in terms of developmental delay, kids that are 33% below where they should be for their functional age in one area, those kiddos we classify them as having developmental delay. Okay, so that's sort of a broad term that we use. Little ones that might present with 2 or more delays, so the areas that we're looking for those delays in is fine and gross motor. We group those together. The speech and language, cognitive, and their social and emotional skills. So if there's 2 or more areas that the child might be delayed in, we classify that as global developmental delay. And this is where RE sits on that spectrum. So there's a lot of different causes of developmental delay, so I won't go too far into those, but we know that there's environmental causes, there's definitely genetic causes, and also health problems. So if you're thinking about conditions, other health conditions like epilepsy or hearing loss or visual problems, any of those things that involve the systems that affect our ability to interpret our sensory information or our environment are going to make us delayed in some areas. So is there a link with developmental delay and hypermobility? Yes, but for not all kids. Okay, so some of the kids that will be presenting sort of similarly to ALI that might only have a developmental delay in one category may have a developmental delay because of joint stability. Okay, so joint stability, obviously we know a lot about that, and that impacts movement and posture, and that might be why a child is delayed. We also know from studies that hypermobile toddlers that have generalised joint hypermobility will have delayed sensory processing, which is really interesting. So that will impact development as well. But for kids with developmental delay and hypermobility, not all of them will have hypermobility as the cause. One of the big causes of developmental delay in these little people that we see is hypotonia. So I want to talk a little bit about hypotonia because it's a condition that absolutely goes hand in hand with hypermobility in little people. So in clinical practice, often we'll get referrals from GPs, and we're looking at a child that's presenting with low muscle tone. So I say, okay, we accept the referral and we do our assessment. When we're assessing these kids for the low muscle tone, which is called hypotonia, we're looking at all of those systems, and we're looking at the connective tissue, and we're doing some further testing to look at the hypermobility as well. So hypotonia, for those that haven't heard of this term before, it's your amount of resting tension in your muscle at rest. Okay, so that is what muscle tone is. If you have hypotonia, that's where you might sit lower on that spectrum, so you might be a little bit more floppy. And if you have hypertonia, that's where you might have increased resistance in your muscles at rest. So hypertonia we normally see in neurological conditions, so that might be conditions like cerebral palsy, other genetic conditions that can cause upper motor neuron lesions that cause that tone. But little ones that have hypotonia, there's a lot of different causes. So hypotonia is caused by the central nervous system, and in terms of regulating that resistance in your muscles at rest. So I think it's always kind of nice to look around because you can pretty much identify people that might have low muscle tone in an audience. So, so with muscle tone, I sort of describe it as, you know, there's those people that you sit next to and they can sit up really nice and straight and they can sit there for an hour and you just think, how on earth are they able to manage this? Whereas if this platform wasn't rattling and moving, I would be very much here and pretty happily here. So I have low muscle tone and joint hypermobility. And in terms of that, so it's not a clinical diagnosis, it is a clinical sign that we'll be looking for in little people. So essentially the message with muscle tone is if you've got a referral and you're a health professional, particularly for kids under the age of 5, they're presenting to your clinic for low muscle tone, you want to be able to screen for low muscle tone, and then you want to also make sure you're looking for hypermobility too, because those two things often go hand in hand. So for a little one with low muscle tone, what they'll present like is they'll be floppy. They'll be like a rag doll. One of the key signs is they'll have increased flexibility. They'll have poor endurance and poor exercise tolerance. So when we're looking at hypotonia, there's no standardised assessment tool that we can use to actually assess for this, which is really annoying. So it's just something that we are using as a clinical observation. So the things that we're looking at, if I've got a little 1-year-old that's coming to see me for a referral for low muscle tone, I'm already thinking there's going to be increased flexibility, so I want to be looking for that. But I'll be looking at a pull to sit test where I'm looking for head control. I'm looking at frog posturing in a supine position, so this is where little bubbies might be laying on their back and they'll have their legs splayed wide and their arms splayed wide. That's another sign. I'm looking at vertical suspension. So when I hold the little person up, do they feel like jelly? Do they feel like they're going to slip through my hands? Or be looking for the scarf sign. So in terms of assessments, we can use the Hein assessment to identify low muscle tone, but it's, again, there's no standardised assessment measure. That's the best tool that we have at the moment. So as I mentioned, hypertonia and hypermobility often go hand in hand. So if you're getting a referral for those little ones, we really want to be able to get better at early identification of hypermobility in little people. So if the referral's for hypertonia, please screen for hypermobility in your little people as well. Okay, and now I'll hand you to Lou.
Thank you, Katie. So I was just going to comment on diagnostics a little bit, obviously being the person in charge of that recent framework. It was very difficult, and we need more data in the younger kids, which we're working on, but it was designed as an international guide. It's an update and an evolution, so if your young person was diagnosed previous to that paper under a different framework, we're not recommending that everyone goes around again. That would be unfair on families and children, but we would recommend it's being used going forward. This little person, Ehlers, she's got a whole list of differential diagnoses, so we have to be really careful with the youngest kids in the last section of the framework in terms of excluding other conditions. So as a paediatrician, this young person presenting with these symptoms would have a CGH array for genetic syndromes. They would have gut investigations to make sure they didn't have celiac disease. They would have a CK muscle enzyme. I'd want to be really sure they didn't have a mild muscle disease, which I've diagnosed in several very fatigued young people. And then the co-diagnosis of the developmental disorders. I'd want to know more about what this young person's skin's like, because that gives us more information about how things are going to change going forward than, in fact, the hypermobility itself. So there'd be a lot of work to do before we got to the what we call final formal diagnosis here. The most important diagnosis for this young person in Australia is their developmental delay, because that's what gets them NDIS. So the rest of it can be done carefully, thoughtfully, thoroughly, and not immediately. So now I'm going to move on to Liz, who's going to tell us about how she would approach Ehlers' leg pain.
Okay, often these, the leg pain experienced by our young children with hypermobility disorders it's intermittent pain. It can be bilateral aches and pains, and they often occurs in the evening or night time. There's no known cause, but they think it's related to periods of increased activity. So if you look back over the day, did they have a play date where they were running around for hours, or was it a day at the beach or a family hike or something a little bit unusual? Now, the pain is usually associated with poorer muscle strength, and I found especially the core strength in these kids is a little bit reduced, and poorer joint stability. And that started me on a research curve of looking at core strengthening in children using a Pilates intervention. I'll be talking about that a little bit more tomorrow in the session 5 on physical activity, so I won't go into it now. But what I find is with children, some of the tips are the therapy activities need to be play-based and fun, or you won't engage the child. The parent knows what's good for the child, but the kid won't participate unless they think there's something in it for them, which is usually fun. You slowly build up the repetitions, and the length of time. The activity is maintained, and that's just to make sure you don't exacerbate any pain or fatigue, or then they won't want to do it again. I usually choose activities that target a couple of areas at once. So in the resource slides, I've got a few pictures. Like one was lying on your tummy on a gym ball with your hands on the floor and keeping your legs up. And that's really good. That's improving core strength, postural control. It's improving the stability around the pelvis and scapular region and the elbows. It's improving the joint awareness, the upper limbs and the muscle strength of the trunk and limbs. Another one might be jumping on the trampoline with hands held, where you're improving the muscle tone, the strength, the balance, but also their vestibular tolerance. So you're looking at the developmental side of things because she falls over a lot. So you're looking at her vestibular tolerance, her ability to move through space, and the actual motor skill of jumping. And another one might be finger games like Incy Wincy Spider, to help facilitate a more efficient pencil grasp for drawing, and even games like that improve the joint awareness of the fingers or the proprioception. It develops the strength of the small muscles of the hand called the intrinsics, their general coordination and the joint stability in the hands. And then you might give them a support like a pencil grip just to help them with their stability while they're first learning to write letters and things. Usually, how much is enough? Usually I find, like with physio, you can't expect to go and see your physio 3 times a week. No one can afford that. So what we tend to do, we tend to be the consultant who reviews the child, gives you a home program to do, just 3 or 4 activities I find, just to take 10, 15 minutes. Any more than that, no one will do it and the kids will start refusing to cooperate. Families are really busy, and so it's helpful to incorporate it into their routine. So just have a chat to them. Are you morning people, afternoon people? Maybe when you get home from kindy, have something to eat, and then we'll do it then. Don't leave it till just before they go to bed because they'll be too tired. And explain to families it's going to take time and consistent effort. There's no quick fix, unfortunately, from a physio point of view or allied health exercise point of view. You've got to put in the work slowly. And what I'll do now is, like with going back to more of the coordination issues that little Ali had, there's emerging evidence to say there's a link between hypermobility disorders and that's the next one I'm going to talk about. So we've finished that one.
We'll do Noah, if that's all right.
Yeah.
Michelle.
Oh, Michelle.
Yeah.
Sorry.
Yeah. I can really briefly.
Yeah.
I don't know if my mic is on. There we go.
Yeah.
So just really briefly, as an occupational therapist, a big part of my role would be to look at the accommodations that these little people need to be able to participate in their daily activities. And when they're going to school or preschool, obviously a lot of that time is spent at those locations. So just looking at what we can do to support them from a fatigue perspective or from pain and coordination, and also the anxiety as well. So really having that collaborative approach amongst ourselves as a team of clinicians, but also then communicating that with daycare, kindy, prep, wherever this little child is going.
Brilliant. So then we'll move on to our next illustrative case, and Liz is going to introduce this young person. Thank you.
So we're going to talk about Noah. Again, this is all made up, but we typically see children like this. He's age 7, he's in primary school. He has been diagnosed with generalised joint hypermobility. He has a range of issues, as you can see. And I think as a health professional, it's important to have a comprehensive assessment. And parents often ask me, why do you need to know that? And the reason is, if a parent comes in with a child with just, knee pain, that's their concern, and we don't ask the right questions, the parents don't know what's relevant and what's not. So it helps us get an overall picture, and that's often how we're the first ones to see these children. You know, the doctors said they're okay, the parents say, oh, they're just lazy, they just don't want to do anything, and we're the first ones to explain to them and start them on their journey of referring to other people. You just asked about medical diagnosis. Obviously, if they've got a respiratory condition or something, it might affect their exercise tolerance. Their medical history is important, like if they're a very premature bub, that can impact on their development. As a physio, from my point of view, we look at the musculoskeletal history, so that's what they came in with normally. The most common presentation we see is pain and what's caused the pain. So we just have to ask a few questions about the cause of the injury to try and work out whether there was a mechanism of injury or is it something that just happened due to microtrauma. And what that just means is that the child didn't fall over, but they might have sore knees because they lack control in straightening their knees, and when they're walking, because they've got so much range in their knees, they flip their knees back all the time. And if you're doing that so many thousand steps a day, then that gradually causes pain. Now, the pain then can lead to reduced strength and fatigue, and then that can reduce your physical activity and impact on his participation at school. Now, it's really important also in these young people to see health professionals who are used to dealing with children. The reason is that like a musculoskeletal adult physio will look at the musculoskeletal sign, but it's a paediatric physio who'll look at both, who'll look at their developmental history, such as, you know, the delay in their achievement of motor milestones, their involvement in physical activities, and usually ask about, you know, cutaway coordination, how do they go compared with their peers at sport. And once you've gathered all this information and then you write down and you see all the issues Noah has, it can be a bit overwhelming. It's certainly very overwhelming for parents. They've known this for a long time and they think, everything's wrong. So that's when it's important that we tease out what are the main concerns, because there's a lot of health professionals that'll need to be involved at some stage, you know, from the GP to medical specialists, from physios, OTs, psychologists maybe for the anxiety, podiatrist if they need orthotics, dietitian, nutritionist. So it's important to remember that families and children are easily overwhelmed. So by many appointments, and they just can't do it. So what we've got to do is to assist the family to prioritise what's their main concern and refer for that. So the aims of physio management are basically to reduce pain, and doing this by improving core strength, joint stability, strength around the symptomatic joint, and build their endurance. And developmentally, with him, we might be recommending activities that improve his active muscle tone, his balance, coordination, and target those sensory motor areas that may be affecting his function. So from a musculoskeletal point of view, you're looking at, you know, pain, joint range of motion, whether they've got hypermobility, and which you screen with the Baton score. And then if they've got painful knees, I'd follow up with the lower limb assessment score, or shoulder issues, you know, the upper limb hypermobility assessment tool, but again, that's not validated in children, so it's just a useful tool to look at the joints. We look at joint stability, muscle strength and motor control. And from a developmental point of view, you're looking at the gross motor skills such as walking, running, jumping, hopping, the fine motor skills such as their manipulative ability, their grasp of pencil. Neurological, you look at their muscle tone and reflexes just to rule out other issues, neurological issues that might be going on, their postural control, their balance and orientation, and their sensory motor, which is their ability to feel touch, the tactile, joint awareness, proprioception, ocular motor, which is eye follow, which can affect your orientation and balance, your vestibular, which is movement in space, and your motor planning.
Thank you, Liz.
Okay.
We're going to move on to talk a little bit about coordination difficulties, but I just want to put the Slido up first. I don't have a button to put the Slido up. I'm hoping some black person in the back of the room could do that. Sorry, person in wearing black in the back of the room. Thank you. Tripped over that. That was bad. Well, really bad. Apologies, not intentional. Bit nervous up here. Do you want to go?
Yeah, while we're looking at, while you're answering the Slido, we just wanted to talk about DCD. So in children that have DCD, which for those of you who don't know, it's developmental coordination disorder. So it is a specific, diagnosis affecting the brain and the coordination of the body. So it affects 5% of kids. So in terms of in a classroom, there'll be one child in every single classroom that has DCD, probably even more. So there's a big incidence of kids that have DCD that are hypermobile. So it's 37% of all kids that have DCD that are actually hypermobile as well. So that's more than a third. So that's massive. So I think if you have hypermobility and you have trouble coordinating your body, that's one thing, and we know that that's from joint proprioception and other sort of sensory systems and instability. But it can be a lot more than that, and it can be another condition that Nicole mentioned. So DCD is the new term for all of the sort of the motor dyspraxias, the motor developmental delays, particularly the motor coordination difficulties. So DCD is the new terminology that we're using now instead of motor dyspraxia in most cases, particularly in Australia. So there's a lot of different causes of DCD. So it can be genetic, it can be environmental. There's high incidence in little premature bubs that will have more DCD, and babies with low birth weight as well. So I think, as Nicole mentioned, kids with DCD are very smart and often have above average intellectual abilities. So in terms of getting a diagnosis of DCD, so if your child's hypermobile, in terms of that diagnosis, you're looking for problems that have appeared before the age of 5, and problems that are impacting not only at school but at home. So these are the kids that might be a bit clumsy, poorly coordinated. They might not be able to do those sort of the motor skills that involve a little bit more coordination, like riding a bike, getting themselves dressed, even pouring their drink in the morning, putting their shoes and socks on. They'll have trouble sequencing and coordinating those specific movements. So in terms of assessment for DCD, if you're seeing a child with hypermobility in your clinic, you should be screening for a motor coordination disorder, DCD, if possible. So the assessment that we use, which is the gold standard, is called the Movement ABC tool. So we're wanting to use the Movement ABC, which also has a parent questionnaire, which helps to identify the kids that will have DCD. But more importantly, how to help Noah. So Noah's a child that has DCD. So we need to really change our focus from impairment-based to performance-based. Okay, so we know there's some really good, robust research in terms of how to help kids with DCD. So there's two sort of main strategies we need to be adopting for our little ones with DCD. So one of these things is task-specific training. Okay, so it's obvious. It's practicing real-life, everyday tasks, and it's breaking those tasks down into meaningful steps. So if it's, for example, Noah wants to be able to kick a footy. So we'd help him to break down that task into the small steps to be able to achieve that task, and it's practicing that repetition of movement. The problem with just doing task-specific training for these little ones is that there's limited transfer of those skills. So if Noah wants to be able to kick a footy, we get him there and we teach him that skill. Then he wants to go and play the game of footy with his peers, and he's trying to negotiate kids running all different directions. He's trying to negotiate fast-moving objects. That's where the real challenges come out. So we need to combine task training with a cognitive approach called the co-op. So the co-op is a cognitive orientation for occupational performance, and it's a strategy where kids are able to problem solve their own abilities. So it uses a checklist and it helps parents to do at home. So it's called the Goal Plan Do Check. So it's basically where kids come up with their own cognitive strategies to help them to achieve their motor skill. So they'll actually write down their plan with their therapist about how to acquire that skill that they want to do, and it all has to be driven from their goal base. So in terms of how to help Noah, the best evidence is using the task approach, so actually practicing the task that he needs to learn and combining that with a problem-solving cognitive approach, and he'll have really good success in terms of being able to generalise those skills and being able to transfer those into other environments as well.
Brilliant. Thank you, Katie. Now, the Slido's just gone off, but I was going to move over to Michelle about school-based accommodation. So could we just pop that last Slido about school back up?
Yeah, if that's not possible, that's okay. I did see some of those answers. Oh, there we go. So I'm amazed, if we think about it, these are all of the different variations and supports that we all need or kids need in a classroom or a school environment, because everyone's different. Everyone presents differently. And that's something that makes it a little bit challenging, because schools then think, oh gosh, we have to try and accommodate all of these things. But most of them are actually really quite easy to put into place. It might require a conversation with school over and over and over again, but we often get there. And if, Lou, can you switch to the next slide for a second, if we can get that slide? I don't know if it's kind of come
Positive
up.
vibes.
Just got a magic
Magic, the slide.
at the back.
Which is talking about the well-being. Go back another one. There we go. The well-being outcomes. So really thinking about the physical, social, academic, emotional and mental well-being of each child. And if you're in Australia, then the Australian Disability Standards for Education is something you probably need to familiarise yourself with. And if you're in another country, I hope and pretty sure you do have another standard for education and relating to disability that you can apply, because it's actually part of the law here in Australia that schools make reasonable accommodations for these things for the kiddos that we are working with and kids with any medical or mental health concerns. So that's really, really important. And then if we go to my next slide, I think, so if we just think about Noah and his handwriting difficulties and fine motor and fatigue and all the things that he's got going on, there are so many things that an occupational therapist, paediatric physio can come in and support. So pencil grips, we've already spoken about, the OT, favourite. I think we all have some in our bags because someone somewhere always seems to need a pencil grip. But it's something that is so simple and so cost effective and can really support engagement in handwriting. We also need to think about the conversation that needs to happen around whether we're doing handwriting or whether we need to be typing, or if we need to be dictating our work or finding some other way to communicate the ideas in the head onto paper, or to be, to assess, I guess, in a school context, whether a child is meeting their goals at school. So they spoke earlier today, I think Pauline spoke about the IEP or the individual learning plan, depending on what country you're in. And that's also really, really important. So these sorts of things will need to go in there as well, just to ensure that there is access to the things that a child needs. So I think from an OT perspective, it's all about engagement in their occupation, and a child's occupation is going to school. So being a student. So our whole role is to help in that school environment to make sure that they can engage the best they can with their environment, the people in their classroom, the materials that they have to use, and making accommodations where we can.
Thank you. And then we've got one last case for the last bit of the case-based discussion.
Yep.
And a few questions coming early, so Get in there with your questions. Michelle's going to present our adolescent case.
Yeah, that's
Thank you.
fantastic. All right, so we'd like you to meet Shannon. Shannon is a 14-year-old non-binary person who uses she, they pronouns. Shannon has a diagnosis of paediatric generalised hypermobility spectrum disorder with the systemic subtype, which Nicole was talking to us about earlier with all the different types. And they've recently been diagnosed with orthostatic intolerance and experience persistent pain and fatigue. Shannon has a history of poor school attendance, attending half days, 3 days per week. They experience episodes of gastroparesis and report restricted eating and nausea. Functionally, they have difficulties with some of their activities of daily living and have lost both their confidence in their body and their independence. Anxiety and depressive episodes are also part of Shannon's life.
It's only the 45 minutes.
Now, as an occupational therapist, I see Shannon holistically, knowing that they have a mind, a body, and a spirit or life force, or however Shannon would like to name that part of them. They live in a context of societal, cultural, personal, and familial customs and beliefs, and they function within a range of environments, including home, school, and community. So if I was working with Shannon, I would be working with them to decide together what their greatest concerns are. So when we talked about this as well with the spider, so looking at what they perceive as the bigger issues for them at this time in their life. So we would be doing that. And then if I was their OT and working with this particular fabulous team of clinicians, I'd probably be working on fatigue management. So looking at pacing and activities and how much they're doing before and after school and on weekends and what's going on in terms of their energy management. We'd also be wanting to make sure that their orthostatic intolerance is being treated well, because we know that orthostatic intolerance that's not treated well can be contributing to fatigue. And I'm sure that's going to be talked about much more in workshops, definitely on Sunday. So we're looking at the pacing, we're looking at the energy management and energy conservation. We're using different tools and strategies to help them to understand that and manage that for themselves. But then we also need to think about school. So what do we need to put in place at school to enable Shannon to attend and to reach their academic and social goals? And I would be looking at, with them, the implementation of self-management strategies. So that could include postural support. It could be the pain and fatigue management, knowing when to ask for help at school and how to go about that. It might also then be looking at the expectations of the classroom teacher or teachers and having discussions with them or putting some plans in place in their IEP. So we're looking at their handwriting output. Is it going to be typing, handwriting, all the combination of all of the above? What do we need to do to manage their attention and their need to sit still in class? Can they maybe get up and move or leave the room if they need to? And then also that variation in attendance and participation. So the expectations from the school and the schooling system on attendance and going to things like camps and excursions and sports carnivals. And some schools have extracurricular activities that are mandatory. And then the big one for us OTs is exam provisions. So what are we going to do about their examinations where they're required to write for 2 hours or 3 hours, which, I don't know, could you write for 3 hours at the moment? So that's just something that we really have to think about as an OT as well, to help Shannon to achieve their best outcomes.
Thank you, Michelle. I'm going to very briefly touch on mental health because this young person has a diagnosis of anxiety and a diagnosis of depression. It's just a very brief call to arms. The most frequent cause of death in 14-year-olds here in Australia is suicide. We can't afford to miss major issues with emotional well-being in our young people. 30% of people with a chronic illness have a reactive depression, so have a subsequent impact on their mental health. That statistic gets higher and higher as you add in those illnesses being chronic pain, chronic fatigue, and the illness being disabling. So if you have an illness that is disabling, it's that you have more of a risk of that having a subsequent impact on your mental health. So those two diagnoses are really key not to be missed. Half people don't have mental health diagnosis, but if you do, we need to identify that promptly and treat it promptly. So in terms of mental health treatments, the psychologists are key. We'll hear from the psychologists themselves tomorrow, so I don't want to talk too much. But just to mention that there's another way that psychologists can support these young people, and that's in more of a coaching and a positive psychology approach. So they can provide support in terms of living and growing with a chronic illness, as well as directly treat any comorbid mental health conditions. So Nick, can you tell us about how you'd work with Shannon?
Can you skip back to Shannon's slide for me, if you can, please? I'll be really brief. I don't want to hold too much of your time. I think, one more. I think, and maybe you could put up the Slido as well, maybe, so, because I think we missed that, the Slido. So I think by now you might know that I'm a bit of a different physio and I do things differently. And I wouldn't be looking at Shannon and saying, let's do core strength or focusing on strength and the typical physio things. You wouldn't get typical exercises because Shannon is of an age, they are 14. At 14, typically teens are wanting to individuate from their parents, but Shannon's relying on help for her ADLs, or for their ADLs. So they need their mum and dad, and that's really tricky because that's not cognitively where they want to be. They have poor confidence in their own body and they're depressed, and that's really hard. So as a physio coming in, my main focus would be understanding Shannon and understanding what motivates them. They love hip hop. Let's find something that feels good for your body. Let's build that engagement in movement that feels good. I'm not going to sit there and correct technique. I don't know if you're a teen in the room or you've experienced physio as a teenager, but like, oh, no, move this. Oh, you're doing it wrong. Oh, like, I don't think Shannon is going to respond particularly well to me. Well, in my experience, they haven't responded particularly well to me in the past. And so my first step would be engaging in movement, and then over time, building towards functional goals, experimenting with different types, but particularly working with a psychologist and the psychologist that's working with Shannon to understand some of the key techniques, because if there's chronic persistent pain or fear of movement present, I need to be really kind in the way we approach new things. So understanding what might you think happened, let's test that theory and let's work with the psych. So if you have some different tools and you notice things in your body that's happening, you might increase in breathing, or you're starting to feel faint, or what's happening, let's see what we can do to adjust that. And so working with that team to really build some movement and some strength and some exercise, and later down the track, maybe targeting some more specific stuff.
Thanks, Nick. I'm now going to ask Cheree to talk about the key role of nutrition in helping Shannon.
Beautiful. Or any of them.
Yeah.
So
all of them.
My point of basically coming to speak to everyone is naturopathy will bring core aspects to support people living with chronic illness. So I was really surprised and sad to see that nobody put naturopathy as part of their care plan. Nutritionists, naturopaths, what we do is look at the whole person. We investigate, we connect dots, and we give you that self-management and education so you can empower yourself and step up and improve your quality of life. So basically it's tell me your story, what's your history, what are your goals? How can I help support you with your goals? And one of the first things I do is, what are you eating? What are you drinking? Are you meeting your nutritional needs? And with all of our cases today, I can probably see that they wouldn't be meeting their nutritional needs. And if we just look at how do we improve the diet, do we need to supplement with things? And we need to do age-appropriate dosing. So as we've established, children aren't adults, and adult dosing of nutrition and supplements begin at 65 kilograms. You can't just halve it. So there is, a tool that we use to work out effective doses, and that's just making sure they meet that RDI, so the recommended daily intake. We might need to go above and beyond that for short amounts of time to get therapeutic outcomes. So pain, what I'm going to do is focus on things like PEA and magnesium, relax, things like this. With Shannon, she's in a lot of pain. So if that's her main goal, I'm going to hit that hard first, but I'm going to also make sure that things aren't going to cause nausea. So we're going to tiptoe in. We're going to look at what her gut microbiome's doing. Are her hormones supported, or their hormones supported, sorry, and also neurotransmitters. So there's a lot to look at, but we can do it in a way that will meet you where you're at with your family, what you can cope with. Obviously, I'm not going to give you a meal plan and expect every single thing to change overnight. It's like, what can we do right now that you're prepared and can achieve right there? And that's what naturopaths do really well.
Yeah.
Thank you.
Well done.
So I'm going to move on to the questions.
I think they've done it, Lou. Oh, the Slidos, you mean, or the actual?
The
yeah.
so the Q&A. So we've got a brief slide on transition to adult care. That was the first question that came through. Essentially, transition to adult care was a concept that the hospitals really started. So in hospital practice, there are paediatric hospitals and adult hospitals. There's a very clear line in the sand. If you walk into ED, and I've had this happen, walk into ED on your 16th birthday with meningitis, they will send you down the road.
Yeah.
Not so good. In private practice and with allied health professionals, and there's often a bit of flexibility, so people don't have that hard stop, and I don't know if it's different in different countries in the world. So transition's a bit less of a problem if you're mainly community-based. In terms of hospital practice, we have some clinics here in Australia that treat children with hypermobility, some that treat EDS, but only the genetic subtypes. We then don't really have adult multi-disc clinics. Canada does. There's a few jurisdictions that do have these beautiful multi-disc clinics. We have some good subspecialists in adult hospital practice. So as adults, you have to be a key part of your care team with your GP as the central point of coordination and record holding. So we need to find better ways of supporting our GPs. There's a lot of interest from GPs in treating patients with chronic illness and supporting patients in the longer term, but we just need to back that up with more knowledge. Any other comments on transition?
Yeah, I was just going to say there's a lot of skills that need to be learnt along the way when someone's transitioning from that paediatric model of care where parents are making decisions, and the last thing we want is for a child to move into adult care and be landed with the responsibility of suddenly having to make a decision that is crucial for them without having these skills and the opportunity to practice them and to gradually start taking responsibility and gradually start learning to problem solve, weigh the risks of things so that things, when they go to an appointment, they don't just agree to everything that is suggested, because that may not be the right thing. I'm sure we've all had experiences like that. So yeah, just making everyone aware that we need to, all of us clinicians, but also families, need to be supporting our young people to gradually start taking on the responsibility so that they can get to that point of leading their own care with their team. So they're the decision maker.
Thank you. I've got another one. What is opinion on the child who has been diagnosed with growing pains and told they will grow out of it?
All right.
Oh, sorry.
You laughed loudest.
I'll start while you laugh. Ready?
We had this discussion in the break.
Yes. Yeah. I remember reading an article. Well, I think it was a letter to the editor after a paper was published on this topic, and the question was posed that growing shouldn't hurt. So why are we saying that growing pains is normal? And that's just really stuck with me, because I don't think we all, I wouldn't say we know definitively what the answer is to this question, but it's not good enough for us to just say it's just part of life and that that's what happens to kids, because it doesn't to happen to all kids. And then we also need to have tools and strategies to help them manage that pain, because it's very real pain. So, Nick, what do you think?
Well, I think everyone puts everything in the growing pain basket. And if a child has pain and that pain is impacting on their function or their sleep, it needs to be addressed.
Yeah.
But we need to figure out why they have pain and if the different types of growing pains. I hate the term growing pains. And that is working in a multi-disc. So I would be seeking support from the GP to clear up things in bloods, like making sure there's no vitamin or iron deficiency, because also for kids that are really little with growing pains, that's their expression. But is it fatigue? Is it we don't know, but they're obviously something is happening and it's stopping them from being able to do what they do.
Yeah.
But I had this discussion with a rheumatologist. They were like, but if it's not arthritis, I'm not sending them on. I'm like, but no kid should have persistent pain that's interfering. It doesn't. We don't have to have a specific...
Yeah. So growing pain, there's a few early childhood diagnoses that we use when we're not sure. Hypotonia, growing pains. Growing pains to me isn't a diagnosis. You need a better diagnosis, especially if it goes on for a few months and it's starting to impact the child's life. Benign nocturnal leg pains is where they wake up in the middle of the night in absolute agony. That one is associated with iron deficiency and it responds a little bit to orthotics. Hypermobility early on is often passed by as growing pains before it goes on for about 3 or 4 years, and someone actually goes, well, we should probably actually do something about this.
Cheree, do you have any nutritional...
Yeah. Well, topically, if a kid's complaining and waking up in the middle of the night, which is how I found out all about this, because my daughter was doing this, and we were actually told growing pains don't exist, and she would grow out of whatever was happening. So topically, a PEA cream with magnesium, checking their iron, zinc, things like that, magnesium-rich foods, relaxation, Epsom salts in the bath, and just making sure that they're having enough protein to support that growth.
Yeah, and the other one that has got an evidence base is orthotics. Hi, Mo.
Hi, Mo.
Mo, the podiatrist down the back. The next one, should we be considering looking at binocular vision dysfunction before we look at developmental issues, as the symptoms can mimic developmental issues? I actually get asked this question a lot in clinical practice. And the kids that come into me that have both hypermobility, a proprioceptive defect, and developmental coordination disorder often have swallowing difficulties from poor oral motor coordination, and often have eye tracking issues or double vision from poor binocular eye coordination. And they have difficulties coordinating movements of their hands, they have difficulties coordinating movements of their bodies, they have difficulties with pronunciation, but it's all part of that motor coordination picture. Next question. It seems like physical education teachers could be important allies. How could memorable information on connective tissue disorders be provided in their training or via schools?
Yeah, Katie?
Well, I've tried to do a few presentations at ASPA, which is like the conference for phys ed teachers, but it's all opt-in to presentations. So the people that come are interested, and so it's just more education, more awareness, either on an individual basis when you're working with a family or at those big events, but it's just slowly spreading the word. Any other ideas?
Just sharing resources. So on the Ehlers-Danlos Society website, there's some good resources for physical educators, for teachers, and where you have the opportunity, like you mentioned, just having that phone call or that conversation with your child's PE teacher, just around what that means, and sharing any just links to any webinars. So all of sort of the teachers that we work with, we've got sort of some short little snippet webinars that we've created, because I know a lot of teachers are incredibly time poor. So even if it's a 15-minute webinar with, you know, links to more resources to help them sort of learn more if and when they have time, but just giving them that sort of snapshot on what the key important things are that might be for that child that's attending.
And I think that's the key as well. It's hard for us to put out a blanket information about these sorts of things because it is so specific to each child. So that makes it a little more challenging, and why that one-on-one interaction often needs to occur. But of course, basic understanding about the impacts could definitely be part of the picture.
Yeah.
Just on DCD, there's some amazing resources on the CanChild website, particularly for educators and classroom teachers on what DCD is, how to best manage it. So that's a really good place for information if you need.
The next one I think is for Michelle, but we'll all contribute. With a 15-year-old, so we've got a legally mature minor who's allowed to make some decisions, but is still not at consenting age, should a parent in general let the teenager decide whether they should go to school, or should the parent try and gently encourage?
Oh, that's a very loaded question.
Tricky.
There's legal, there's the education department and their rules. They do knock on people's doors, unfortunately. They send them a letter. They don't actually physically knock on the doors. If a child doesn't attend enough and they get flagged by the department, at least that happens in New South Wales. So that is a challenge. I think my approach would actually be working out why school is such a barrier, like what the barriers are to getting to school is really what I'm trying to say. So kind of looking at it from that approach rather than yes or no to who should make the decision, because I think it needs to be a supported decision. And it all comes also in like the idea of, I guess, maturity as well. Yeah, I don't know. It's a very tricky one.
Yeah.
Lou, what's the doctor version?
Very challenging.
Yeah.
You physically can't extract a 15-year-old from their bed and get them in a car to go to school. So there's a practical barrier there anyway. So if they
My
really
mother used to.
don't want to go,
That would be some kind of abuse. So we don't want to do that.
So we don't want to do that. It's so it's about the communication again, communication with that young person, communicating with the school, working out what is happening, making sure we've got fresh eyes in terms of diagnosis. Is it severe fatigue? Is it low mood? Is it both? Is it severe pain? Are there physical barriers? Is it just too hot and their POTS has gone right off? Is there an alternative setting? So I've had quite a few kids recently that are in smaller schools in alternative settings, and that's suited them really nicely. So the smaller schools, as high schoolers, don't move classrooms, lots of additional psychosocial support in the school setting.
Yeah, and we've also worked together on cases where we ended up having like a mixed mode of attendance. So they would go to school for 1 or 2 subjects, but the rest would need to be at home. Yeah. That is very dependent on how supportive the school is and the department. But there's distance education. We shouldn't be forcing people into distance education, but it is an option. There's homeschooling. I think there's lots of things to explore in that kind of setting and situation.
R11, I'm just picking these at random, so if we haven't answered your question, we will try and make sure we answer them all. Our 11-year-old gets severe mouth ulcers that stop him eating. Some vitamins have helped, but he still gets them and can only tolerate ice cream. Prevention for Cheree.
Let's look at the oral microbiome and see what's happening there. So there's some really cool probiotics that target oral microbiome. I would probably do liquid nutrition, so something that would get your nutrients in that isn't going to exacerbate it. Look at healing the cells, so glutamine, zinc carnosine, nutrients that target cellular repair. So they're the things I would do. There's some things that you can swish around your mouth that will help with repair. So if we can't swallow yet, let's start with swishing what can get in there and fix it and then spit it out until we're able to swallow. That's where I'd start, gently.
Yeah.
And then there have been a couple of similar questions about neuromuscular disorders that could be mimics or phenocopies. So the diagnoses I've made have been the rarer but milder muscular, like true muscle disorders. The best thing, if you're particularly concerned, is ask the GP for a blood test for a creatinine kinase. It's quite sensitive to muscle dysfunction. With my kids, I recommend the parents take it on an active day or late in the afternoon after the kid's been quite active. But if your physio is saying your muscles are not responding to exercise, I'm not seeing your muscles getting stronger and more efficient with exercise, and you've got a lot of muscular fatigue, so your muscles stop you moving before anything else, then it might, and it hasn't been checked in the past, it might be worth.
Or if there's regression in motor skills.
Yeah.
So like if your child's losing motor skills, that's a really big flag as well. I've seen a little one that I was really worried about, a muscular dystrophy, but they had just had such a significant viral illness that was extended.
They'd given them a myalgia,
almost mimicked.
Myositis.
Yeah,
like muscular dystrophy.
Yeah.
Until it got better. So not making progress is a big red flag. And then the severe muscular dystrophies present in very young children with motor delay and often some other signs. But the milder muscular dystrophies can be a child who's fatigued, poor motor skills, poor motor coordination.
And just checking peripheral reflexes, peripheral tone as well, and any neurological changes in the limbs, particularly looking at any increased tone as well.
In regards to developmental coordination disorder, can children develop strong skills in specific areas through concentration and practice?
Yes, they can.
Yep.
So they're called,
Good job, the parent.
they're called splinter skills. So what a splinter skill is when you are assessing a child for developmental coordination disorder, and we use the movement ABC in our clinic. And commonly kids will have one particular skill where they're actually scoring in the normal or the typical percentile, or even above that. And that's the thing that child has practiced and repeated and has nailed. So often a score profile for developmental coordination disorder, if the scores are all significantly low, then that's really indicative of that child's participation, potentially some other comorbidities. But it's very common to see in a score profile, or when we're looking at child's motor skills, they might be amazing at fine motor skills, but be really terrible at bike riding and not able to kick a footy and not able to balance on one leg. So that is quite common and typical for what we see in kids with DCD.
Yeah, so what I say to families is DCD is a motor learning problem, not a motor doing problem. I've got a young person who's an elite rock climber, and I've got a couple of elite swimmers, but early on they had real difficulties with the foundations of those skills, but once it clicks, once they have the skill, different part of the brain, it's the cerebellum, not the motor cortex. It's like you drive without remembering what you've just done.
Yeah.
Because it's automatic.
And I would say the same as an OT with shoelaces. It's one of the main things. We practice shoelaces over and over and over again, and it can take years for some kids to actually master learning to tie their shoelaces. But once they know how to do it, they can do it. because it was the learning of it and the laying down of those pathways in their brain of this is how I do this that was the problem, not actually being able to move their body to be able to do that. So,
and we never want to steer kids away from trying anything. Like if they really want to be great at netball, absolutely, we'll give them all of the support, and because we really need to play to the child's strengths. But if you're finding, that they're really struggling with that participation, just looking at other skills that involve, or other activities that involve a lot of repetitive movement. So kids tend to be really successful in sports such as swimming, such as bike riding once they've mastered that skill, things like rock climbing that have that sort of same repetitive action rather than fast-moving, fast-paced sports that involve multiple sort of parts of sensory stimulation that they've got to filter out. So things that move and change quickly and are unpredictable, they're often the sort of skills that kids with DCD might find challenging longer term.
And same with handwriting as well, like shoelaces, handwriting. It's just what we do a lot of with DCD. Is that
you can see that if we can actually think about these things as health professionals earlier on and make a diagnosis earlier on when these skills are still developing in that 3 to 6, 7 year age period, we can make a significant difference because that's when they're creating these motor pathways. We're not coming back to it. We can always come back to it and learn new things as we get older. It's just much more effective and efficient.
And never write things off either. Like we've recently had a 12-year-old who all they wanted to do was to be able to ride their bike with their brother, and have worked with lots of different health professionals and just weren't able to get there. Got a diagnosis at age 12 of DCD. We use the co-op and task practice, and they're now able to ride their bike with their brother. So, which is pretty cool. So, don't think it's just because they're a teenager and they can't ride a bike or they can't tie their shoelaces. If it's important to them, using some of those evidence-based tools like the task practice and the co-op are really successful for these kids.
Yeah, and that one takes me to another really good question. Apart from waiting for them to grow out of it, how do you support teens who have been under medical and allied healthcare since birth and now refuse it all?
Oh, it's so common. Like that stage of refusal across kids with chronic conditions, that's the most common feature is like your kids with cystic fibrosis refuse to start to do their airway clearance. Like you're like, I don't want authority anymore. It's a really common thing we hear. I don't know.
I think it's that like having agency and being able to make a choice because one of the most important things that one of my own doctors said to me was, Michelle, it's your life, it's your mind, and it's your body. That's it. You get to decide what happens to you, because I think we have so many of our young people and adults who have all of these things done to them for all of these years, which as a child, they're not actually consenting to, their parent is. So they're getting to that point where they're like, okay, I don't want to do it anymore. And I say, okay, how about we just make a little bit of a safety plan? What's going to happen? What are you going to do if X, Y, and Z happens? As long as I know they're going to be safe and that we can check in again at some point, then we have to let them, right? Like we can't force things on them as parents or as clinicians. So we just have to support that decision, respect their choice as well, but being really kind of gentle with a bit of a nudge towards, well, is that going to get you where you want to go? Like towards that goal of a better life, better quality of life, like we were talking about, being able to do the things you want to do. So it's not there's no one right answer.
Yeah.
It has to be a conversation that's just ongoing, I think.
And I was going to say, Michelle, when they come back, like if you give them that agency and it doesn't turn out great, I think the worst thing a health professional can do is like be like, well, I told you should have done your exercises.
Yeah. It's always, I'm here.
No
I'm
judgment.
Have you done
just
your
be
exercise?
like, cool, okay, well, let's move forward. How do you want me to help you? Like, ask them.
And we're here if you do decide to come back,
Yeah.
and probably when you decide to come back. But we won't say it that way.
Letting them make
I'll see you.
make wrong choices
See you in a
will
week.
help them as well to be like, actually, I did need that. So I've got an autonomous, strong-willed teen, and I'll be like, I really want you to do this, and this is why. However, it's up to you. This is what I can feel happening if that doesn't happen. And same with it. I feel like at the moment, that's the type of client that comes to me as a naturopath as well, because they're sick of everybody else telling them what to do, and I have to gain their trust, show them the way, but leave it up to them. This is you. This is your choice. I'll give you the tools. You have to pick them up.
We use the Super Mario effect. So has anyone played Mario? Like you have to jump and then you hit and you fall down. And so we say, okay, well, you fell down that hole. Let's not fall down that hole again. Let's learn from it. And back to the start, and we'll start again. And so it's like you're constantly leveling up with more knowledge, but they've got to play the game themselves.
Yeah.
And I think giving them choice, there's different ways of achieving the same goal. So rather than just saying, I think you need to do this, saying, well, would you prefer to do this or this or this, and giving them a choice, and they feel like they've invested in it themselves.
Yeah, that's important, that investment.
And if you've got a young person with a chronic illness, chronic condition, it's really important that their practitioners are their practitioners as well as your practitioners. So even with my 7-year-olds, I'll spend the first 5 minutes of a consultation asking them to tell me their story. And then by the time they're 15, I've done that for 5 years, 8 years or something, and they can more readily tell me, even if things aren't going so well, they can readily tell me their story. So, and same with the physios and OTs. If the young person's got their own relationship with their health practitioners, then take them to their health practitioners and see if that gives you any little improvements.
Yeah, and sometimes it's meeting them where they're at as well. So for me, it might be that they actually just don't want to go to another appointment, so telehealth. Or if it has to be an email, that's cool too. If we're checking in, we're making a plan, that's okay. Having that choice and the options. Yeah.
So the next one is, what is your go-to non-pharmaceutical approaches for effective pain management at home?
That should be a slide.
Again, it depends what's causing it. Sometimes muscle cramping, you can just, show them how to gently stretch the muscle out, or use a heat pack or something.
Yeah, so variably heat and cold. People often ask, should it be heat or should it be cold? But if it's a long-term pain, whichever works for you. I like Epsom salt baths, but if you've got POTS, you probably wouldn't tolerate the hot, so you might want the spray.
Just doing a foot bath as well, or just getting one of those big flexible bucket things from Kmart or whatever, and putting the water in that, and the Epsom salts, just sitting on a normal chair, so you don't have to get in and out of the bath, any of those things.
Just some other mindfulness as well. So any sort of meditation practices. I always encourage, particularly a lot of teenagers that will present with sort of cervicogenic headaches and cervical instability, that kind of thing. Just that load of spending a lot of time texting their mates and having a really sore neck. So just Snapchatting, TikTok, So just that full body rest. So having a beanbag at home, making sure that they're actually laying down, not completely flat, but for their POTS, but just having that period of rest, just to take the load off their muscles, can really help with fatigue and for pain as well.
Listening to an audiobook or something supine, on their back. Definitely.
Look, we deal with a lot of pain in my house with the kids and myself, with injuries and this condition that we all live with. So in my toolbox, I've got a TENS machine. I've got lots of little vibration-y things so I can get spots on. I use patches with emu oil or, different topicals. I take PEA. I often prescribe that. Curcumin, boswellia. There's lots of herbs that are amazing to block the pain pathway. Magnesium is crucial. We're often deficient in it. It makes a difference. You've got to get the dose right. You've got to get the form right. You can use it topically. You can take it in powders, in capsules. But what I wanted to say with that, make sure it's clean, because you might be taking something that's flavoured that has excipients in it that then can trigger your MCAS to flare, and that's not cool. With the headaches, what I've discovered lately is you can get this cool little tool for beauty, which you put in the freezer.
Yeah.
And if you get that right at the root here, oh man, it's awesome for a headache.
Ice pack.
So it's like a roll. Well, I use a roller that you
Yeah,
put
that's
just
the face mask.
the face one. Yeah. Put that in the fridge or the freezer.
Here, put it here.
Back
yeah.
here, you can get eye masks. You can get rollers for your head.
Yep.
All sorts of things.
And being aware of your triggers as well. So, you know, smells trigger me. I travel a lot. I go away with eucalyptus spray or a little mould spray so I can just clear the room out when I need to. I travel with earplugs, mask, all the things that I need. You know, at home you've got all these accommodations, but it's when you go out, don't be afraid to use them. Well, you've seen me wiggle around. I need to, otherwise I'll be hobbling away. So,
Lots of parents say to me, Nick, how do I help my child when they say, I'm in pain? Like, what do I do? And there's so many things that we can suggest, but often the teens say, yeah, I'm in pain, but it's annoying, and I'm actually really angry because I'm missing out on X, Y, or Z, or I'm feeling really sad because this happened as well. Like, this is in the context of my pain. Remember that pain, there's always a context around it. And so often one of the things that I suggest to parents to be able to help their teenagers or children with the pain is to actually look at that context and look at what the emotion is around that context and problem solve. Oh, you're missing out on your friends, like, and you know, and you're really angry and you're also in pain. So let's use those. But then maybe we can do this, which will help you see Sam on the weekend, and we can do it shorter, and you can problem solve. And there's actually research that shows that builds your child's capacity to problem solve so that they can participate in spite of pain.
Yeah.
So yes to all of those things, but for parents in the room, hopefully that might help.
And actually there's an app that I recommend, and I've used it myself. It's called Curable. It's a gut hypnotherapy app for pain. It teaches you to reframe things. So I was at the stage where I was just like going, on my knee, on my knee, on my knee. And then I used this app, and I was like, I'm not even acknowledging this. I'm going to reframe things. And it was amazing. Along with all the other things, it's that holistic approach.
Yeah.
Everything in the toolbox.
Yeah.
Do it all and it will help.
Can I just add as well, similar to what Nick was saying, but that there's obviously the pain psychology side of things. Very controversial for a lot of people, so I don't want to say too much. But the way we think about our pain is really important. And if we are thinking this is the worst pain I've ever experienced over and over and over again, the pain is going to feel really, really bad. So just working on how we think about things, but also knowing that if we have mood problems, then our pain experience is also going to be different. So what can we do to improve our mood will also help with our ability to cope with our pain, I think, because that's what it's really about, right? It's learning how to cope with the pain rather than how can I make my pain go away, because I haven't worked that out yet. I've been doing this for a while, but it's how can I cope with what I'm experiencing in my body, and what supports can I put in place for myself from all of these things that will help me to manage.
There's a little spiral diagram that I like to draw for people, which is pain impacts sleep, sleep impacts your dietary choices impact pain, pain impacts sleep, impacts mental health. Where are we going to break the cycle? You can get it in there and break it any way you can, but you have to break that cycle.
So next, a bit of a change. 41 seconds.
Yeah, you've got 1
can
minute
do it.
left.
Fine.
We've got our 1 minute.
We can do it.
1 minute remaining.
We could talk all day.
So there was a question early online about, I'm getting the boss
30
says okay,
seconds.
but be quick.
getting
One more question.
There's a question online about sports choices for children with hypermobility, and as usual, it depends on the child, it depends on their motor skills, it depends on the sport, it depends on the coach, it depends on their physical capacity. So when I'm prescribing sport and exercise, so I actually prescribe sport and exercise very specifically when I see young people. The only universal thing is if people have got very hypermobile cervical spine, I don't let them scrum, tackle, or dive into shallow water, or go on quad bikes or show jump horses.
Anything that's going to fall off.
There are some children that are in a place where they can't really participate until they've gone through a bit of rehab. But you really need a good exercise professional, physio, rehab specialist, EP, prescribing you a specific program depending on your overall hypermobility, strength, skills.
But if your child's participating and they're enjoying it, you shouldn't pull them out as a preventative measure, or like you shouldn't pull them out of sport. Like if they're enjoying it and they're
Unless it's their neck.
Unless
the
it's
only
their
reason.
Yes, but if they, the activity is important from not just a physical perspective, but a social perspective as well.
Connection and the joy.
Yeah. Quality of
And
life.
you'll find most kids, like if they're keen on gymnastics or something and their body's not coping and they're always getting injured and pain, they'll realise it in the end, and that's when you can talk about other more suitable things with less impact and that they can do.
Thank you, everybody.
Hi everybody, welcome back. Thank you so much for making it through to the last session for today. We really appreciate it. Welcome everybody. This is our final keynote panel where we're going to be having a conversation about how multidisciplinary teams work and the value of multidisciplinary teams. What I'd like to do is, because we have a few people who you haven't met before, we'll do a very quick round of introductions the way we did earlier today to bring everybody into the room. So Luke.
Sure. My name is Luke Hassan. I'm a dietitian from Melbourne. I work at Active Health Clinic, and what I didn't mention before is I'm part of the international consortium as well on the Diet Nutrition Working Group.
Louise.
I'm Louise Tofts. I've just introduced myself. I'm a paediatrician, paediatric rehab specialist from Sydney.
Thank you.
I'm Prashant Rao. I'm a neurosurgeon from Sydney.
And I'm Alan Hakim. I'm here from the Ehlers-Danlos Society based in London in the UK. Claire.
I'm Claire Francomano. I'm a medical geneticist based in Indianapolis in the US.
Dacre.
I'm Dacre Knight. I'm the medical director of the Mayo Clinic Ehlers-Danlos Syndrome Clinic.
And I'm Pauline Slater, physio clinician and researcher at this point in time, based in Adelaide.
Thank you so much, everybody. And a particular round of applause for Dacre, who only turned up first thing today. He and I are both struggling to work out whether he's really 8 hours ahead of you or 16 hours behind you, and we can't work it out. So, okay, well, we have a series of questions, and the way we're going to run this is sort of ask the STEM question of an individual first, and then open it up to a wider conversation from the panel. So I'm going to put the first question to Claire. Claire, why is multidisciplinary approach to care essential when working with EDS and HSD patients?
Well, you answered that question this morning, Alan, because even the smartest clinician, you said, such as yourself, can't
Good
know
answer,
everything.
Claire. Good.
And I always say I think medical genetics is a great specialty for people who like to be generalists. So even those of us who are really interested in managing multiple different complex conditions, we just can't possibly know everything there is to know about managing POTS, managing GI dysmotility, managing allergy and the MCAS symptoms. And not to mention, I mean, we're head to toe, right? Every single organ system. So in order for us to provide optimal care to our patients, we have to network with colleagues who can fill in the gaps and communicate with those people and coordinate with those people so that it's a seamless provision of care for all the various signs and symptoms that our patients are dealing with.
Thank you. I'm seeing nods from lots of people. Any other sort of thoughts about the importance of the MDT?
So I'm a simple neurosurgeon, so I can deal with one or two at a time. When a patient comes with heads, you're then thinking, oh, okay, what else can I manage? And I think in certain places, or in most places, you don't have a very good multidisciplinary system. I think some units, I don't know if that is the case in US or in London, we do not have this kind of a teamwork. And you're not only being a surgeon, you also should be thinking about, okay, their problem is POTS, where do I send them? Their problem needs a physio, who should I send it to? And they need a upper GI, specialist to coordinate them is a massive work. But if you don't, they tend to fall into a heap of, complications or not a good result from whatever you're trying to do. Yep. So I think it makes a huge difference to have a multidisciplinary approach for particularly IDS.
Yep. I also find that different colleagues will have different ways of thinking about things. We're all ultimately on the same page in terms of our desire to achieve care, but sometimes the different ways people think about it, the different ways people describe things, the different way people think about assessment and treatment, all can have a really rich influence on the overall way in which you manage somebody holistically, because we just think differently, right? Dacre, just thinking about this idea of pulling a team together. I know you've had a lot of experience over the last few years doing this. So what does an effective team look like?
Well, it is certainly multidisciplinary, and it would include multiple specialists. And as we talk about, really one person can't do it all on their own, but I guess we think also, why do we have medical specialties to begin with? Because there's just too much for any one organ system to be have an expertise in that area. And you certainly don't want me doing neurosurgery, even if it is very simple. But I'll tell you one thing, that the patients who come to us, they often don't know where to begin. And so they may have some inquiries that they don't even know what to ask about. So knowing what kind of colleagues you have in your team and who's able to do what, that's really what's most important. And then developing that team. So, communicating and staying in touch and reinforcing that network is going to be for the best bet for the patients.
What's your experience been of the way in which the team kind of grows?
Well, it does grow, and it's remarkable how that happens, because I think as we see in the world of EDS in general, the awareness grows, the patient volumes grow, the requests grow, the demand grows, and our knowledge grows, the research grows, and all of it coming together means that there is a growing network. And certainly get yourself on the provider directory if you haven't done that yet already. But if you are in a local area where you may have some providers who are not on that provider directory, reach out to them, and maybe you will find that they're seeing some of the similar patients that you're seeing. I know that story has been present among some of our colleagues in the United States, where I was treating these patients with headaches, and I didn't realize what POTS was. I didn't realize what these gastrointestinal symptoms were until I talked to a friend or a colleague of mine. So that's why that partnership is important.
Yeah, thank you, Dacre. Pauline, just thinking, you may have healthcare professionals who are working in isolation, but ideally you want people to be networking with each other. But where do patients tend to seek help first? What's been your experience?
I think, just as Dacre mentioned, it's a broad brush across where patients may enter into this space of trying to find out what is going on for them. Sometimes they might see their GP first. I think a majority of patients would touch base with their GP here in Australia first. But if it's pain, and we know that pain is one of the number one symptoms, and fatigue, they're going to head to their physios and their osteos and those sorts of places. Historically, with the siloing of our specialties, I suppose in Australia, rheumatologists have been our number one place if people are thinking connective tissue. However, we're watching a shift in Australia as not as many are taking on our EDS patients or connective tissue disorders. And so where do they go? They could go then to other, they just move on through their specialties. And if often finding a really good central GP who's got information and is EDS or connective tissue aware can be the key to the whole unravelling of the symptoms, and then the beginning of the solving of all the multi-system body-wide problems. Yeah. It seems to be what we're seeing, and we've got some basic research that came out last year, but it's still taking a long time to get people diagnosed in our country, unfortunately.
Yeah. I'm going to ask Luke, I mean, you may get people that haven't had a diagnosis that turn up, to come seek help from a nutritional point of view. What does it feel like in terms of the availability of networks, access to people from a multidisciplinary point of view, when you've spotted a possible diagnosis and you think, I now need some help?
I certainly think it's been much more we've had much more access to people who are able to at least further that diagnostic process over my time working with these conditions. When I started, it was very challenging, particularly in Australia, to find someone who was willing to take that next step and engage with 2017 criteria or whatever it happened to be, or whatever that person was willing to engage with. So I think slowly but surely we're getting there, and that is a massive. It's really due to the work that events like this and the society and the people that are coming together to collaborate in these areas are really driving. And if we didn't have events like this and movements like this, we would still be stuck where we were 5 or so years ago. So yeah.
Well, my experience of our network in London, which has grown over about 25 years. So when people sort of say, wow, you've got a great network, it's kind of like, yeah, but it took a long time, a lot of watering, a lot of nourishment, is that now we're in a really lucky position that if somebody does present for the first time, for example, in a gastroenterology clinic, and people are not quite sure about the diagnosis, then there are lots of multiple places where they can touch points and get the expert opinions from others, and it's hugely valuable. The area that I see as most vulnerable and where we really need to tackle the most, I think, is those first touch points, either in primary community care or in the emergency room, accident and emergency, or even first responders. And so a big piece of work that we're trying to do now is really work with that kind of swathe of colleagues that are out there in the community. That a bit of distance away from us really more in our specialties, but I think the specialty networks are really starting to find their feet. And I can see this, and I think there's going to be some discussion tomorrow about some of the networks in Australasia. Louise, I want to come to you. So we're in a great position now. We've made a diagnosis. We've got a great team around us. But what do you see as the kind of common challenges for healthcare teams when diagnosing and managing people with EDS? And how can these things be addressed?
So in terms of diagnosis, you often do get slightly different opinions from different people. We also get the common situation I come across is the Baton score I get is slightly different to the Baton score others have got. But I think that's because I see young patients and they actually genuinely change. So it depends on time of day. The POTS diagnosis, they've gone to a GP and there's a not quite sit-to-stand test, and I do the test in the late afternoon and it's negative again, and they've got clear symptoms. So I think there are some of these tools that we're using aren't as black and white accurate as we think they are.
For sure.
So we have to be careful about those greys.
Yeah. So there's the intervariability between different people doing the assessments, but
different
also
day, different time, different
earlier
amount
on
of
this morning, I think Pauline, Nicole had said that you can do a test for POTS and it can be different times of the day.
Absolutely. Yeah.
Yeah. Can I ask you the question about the people who don't believe the diagnosis and how you get treated by your peers who just simply don't believe that you've made a correct diagnosis of EDS or HSD?
So
or dare go so far as to say they tell you it doesn't exist?
So I haven't been directly challenged yet, and bring it on if there's anyone out there.
I want to be there when you.
I do sometimes see patients who've got comorbidities and actually have chronic fatigue rather than hypermobile spectrum disorder. But no, what I say is everyone comes in for help, for a diagnosis and help to find their path, and everyone leaves with a diagnosis and a path. And that's universal, and it doesn't matter. Like there's talk about a hierarchy of diagnosis. It doesn't matter what your diagnosis is. You don't choose what your diagnosis is. There aren't good or bad diagnoses. Like there's no quality measure, and it's just it is what it is. But if your life's being affected by your health, we have to find a way forward for you.
Prash, we were talking earlier today about colleagues' opinions. What are your thoughts?
Oh, it's very challenging, particularly amongst your peers. As a surgeon, if you do anything wrong, even in the right sphere, in the right idea, it's challenged. So the way of kind of to move forwards is research, networking, whatever you believe in, or we discuss, or we find on the online in terms of the research, you put it on to test, and then collect the data. I think data is massive, so important to prove that what you're doing is right. So, and I think having a colleague that you can vouch for and get a second opinion for every diagnosis you make makes a huge difference. Yep. Otherwise, you're going to be in the basket of he's crazy, which I think, which for patients you want to help them, right? So we were just talking about this, me and Dr. Henderson, that when you get a patient, you've made their life massively different. You want to fight for it. Even for me, if I want to do 100 simple cases, it's easy, not less time consuming than make a life-changing decision on one patient. But to do that safely, I think research and data and networking makes a huge difference.
Claire, can I bring you back in there? Because I'm thinking about the core networks, the centres and networks of excellence, and also the work that we do with ECHO. So one of the things that I find really valuable as being part of an MDT and a network is that opportunity to do that much wider set of research, but also the safety, if you like, or the validation of being in a group. Some of your reflections on sort of the CNEs and ECHO.
It's just been so very valuable for me to have the opportunity to speak with colleagues literally from all over the world, because people bring perspectives, different practices, different ways of thinking about things that you wouldn't get from your little insular group in Indianapolis, for example, And I think sharing cases through the ECHO program it's really, really helped the way I practice medicine, and I hope it's been helpful to many others also. And the core groups, there are two kind of opportunities with that. We have our local group, which I think is super important for maintaining the multidisciplinary team locally. But then also the opportunity to speak with others who are participating in the core program. It's the same kind of thing that we have with the ECHO, to bring best practices into discussion and different perspectives and things. It's been very, very helpful.
And we get a lot of different perspectives out of Indeka. And you guys have been very heavily involved in these kind of networks. And what are your thoughts on the perspectives that people share?
Yeah, the one thing I enjoy most about it is that, I think, to carry on Dr. Rao's comment, is I don't think any of us go into this because we were looking for the easy way to get through the day, or just some easy money, right? There's a passion behind it, this challenge, but also the resolutions that we come upon with it. And that shared mission is what I think we all partner together with, and you get a sense of that. And it's also something I'm sure you patients feel as well. And you come to programs like this, and that energy, that eagerness to learn, it's palpable in this room. And I think that's what's the best quality about those programs.
Thank you. Any thoughts?
And I think from the EDS ECHO point of view, particularly here in Australia, just watching it launch 6-7 years ago as to where we are now and how many people are joining online and inviting people online, and patients being more empowered to then reach out if they've made that one touch point with the good GP or a good physio or a dietitian per se, that they then actually, patients have enough information behind them through the EDS Society and themselves, that confidence to pass that information on to their other multidisciplinary team members, be it specialists, healthcare professionals, to join in and gain more knowledge and grow that group. Because what we learn online, like Australia is a huge country, we can't all be seeing, in Adelaide alone, there's only a handful of us, etc., etc. But what I can do via telehealth and what people can join in from in and around Australia or around the world brings such valuable help to such complex conditions. And we need that input because, as we're all echoing each other, human being is a complex EDS is complex, and there's no way we can know it all. And we're not here because we like simple.
Luke, I want to bring in a question to you about thinking about your team and the wider way you communicate with everybody. How do you ensure that all voices within the team are actually heard? Integrating everybody, including the patient, into care.
Well, I think it needs to start with the patient, Alan, as I sort of talked about in the first session, and it's been echoed all day. Each person with HSD, they're going to bring an individual story, going to bring an individual set of circumstances that must be taken into consideration by that primary clinician, and that might be me because I'm the first port of contact, or it might be a GP, or it might be a physio, or it might be a paediatrician, and it'll be someone who knows the conditions and who's invested in taking the time to understand them further and work with others to really get this stuff sorted. And if we listen to the patient first, we'll often then find a really suitable way and the easy way of incorporating the rest of the team to be involved and figuring out who needs to be on the team. But I really like the idea of having a sort of team lead. And in Australia, we'd love that to be the GP. Sometimes it's not the case. Sometimes it will end up being an allied health clinician. Sometimes it could be a medical specialist, but you guys are so busy and you've got so much going on, and not that we don't, but maybe sometimes we can facilitate that. Just that, because that's who the person's come to first. Mm-hmm. But I think if you really listen to the patient, then we'll work out a way to get all of those voices heard. And then there's all the obvious things, timely communication between team members, making sure you're getting those multidisciplinary team meetings up, making sure that you're finding the right referrals to send people to. And I think that's been one of the most valuable things to come out of the core networks and the echoes, is to find these people who have this shared passion. And when that team leader is someone invested in the situation and you have people with shared passions come into the situation, then you're really going to make sure that the patient's voice and what they need to have done is communicated and then acted on effectively.
Yeah, thank you very much. Louise, just picking up on that, we were talking earlier about how to effectively bring patients and their families into the team as part of the team. And how you build trust in that relationship, because it might be familiar to us, but it can potentially be either alien or even somehow threatening to be invited to become part of an MDT if you're a patient or a carer. What are your thoughts on effectively bringing people in and building that trust?
So multidisciplinary meetings are quite a challenge. It's really important that there's a clear leader, in my experience, even if that's not necessarily the person that does the most doing. I always prep patients before I put them into a group, because it can be really, especially for children, can be really quite confronting. We used to have this orthopaedic meeting where there were literally like a stack of 40 orthopaedic surgeons.
Right, scary, right?
And the kids had to go in their shorts, and so that used to require half an hour of prep and then half an hour of debrief. Mm-hmm. But it was often valuable because the surgical decision was made between 10 experts. It's important that everyone's voice is heard, so it's important that we go around the room. I try and make sure that the voices are going to be coherent, because if one of the team is on a really different path, that really needs to be resolved outside of the meeting with the family, because it's not, as a family or patient, it's not your job to deal with conflict. The team needs that coherence. There was an example where my granddad had just had a stroke and he was just recovering, and the consultant who came round had a massive go at the registrar, and he could barely speak because of his dysarthria, and he stood up and said, "You can't do that. You can't do that." And that was the patient. So so we've got to be all on the same page, and the patient's got to be the focus, because there's lots we can do, but it's about what you want us to do.
Right.
Out of all the different problems, what do you want us? Where do you want to start? So it's about the meetings are about goal setting and focusing care, and often that can be about less care as well as more care. Some of my NDIS patients are getting hours and hours of therapy and actually not getting anywhere because they're trying to learn too many things at the same time. You actually have to say, "Hang on a minute, what are your 3 most important health priorities? Don't worry, we will deal with the next set of priorities in 6 months' time. We will deal with even more priorities in 12 months' time. But what about right now? What are you interested in? What are you keen on addressing now?
Yeah. And Pauline, we were talking about the complexity of EDS and HSD from a healthcare professional's perspective, but how do you balance that conversation against the goals, the aspirations, the desires really of the individual, the patient that's in the centre of all of this?
Louise has just addressed that concept of like asking the patient, and it has to be patient-centric, not physio-centric or GP-centric. It has to be patient-centric, and it's what's most important, I think, for the patient right now. And we have the spider model, but many of us have known we extend the spider model. I think you mentioned earlier this morning, like we've moved from 8 legs to 10 legs to so many possibilities there. But for each individual person, it's so different on as particular day, particular time. Child could be transitioning between preschool and school or school and high school. That might be the main issue on the table in the next 3 months. It needs to actually be the thing that's addressed. And then patients themselves, often in this journey of getting a diagnosis, have lost who they are because they become so that they need to get that diagnosis. They're on that way to try and work out what's holding them back, and they've given up so many of their friends, their social, their art, their hobbies, the things that bring them joy and love, and then all those things feed into their holistic health. So it's like putting that on the page as well. It's, if you would like to look at that social aspect of yourself, it's that biopsychosocial and you and your family approach. Let's get a balance here. But what's most important at this point in time, and we can only focus on 1 or 2 things today or in the next 2 months, but view it as that big jigsaw puzzle and go, we are going to get to it. Don't worry. You're in the right hand, we've got a team, we're going to keep building that team. It may take a while to build that team. Being very honest and just keeping the patient always going, what is the most important thing for you today? How can I help you today? And where do we need to be stepping off next? Literally got that email this morning going, NDIS is on my back. They need the letter that says it was okay for me to buy the blah blah. And you're like, obviously that's the issue today. So keeping it at the centre and asking patients to use those tools that are out there that we use as therapists, I suppose, and health professionals, not just from our point of view, but asking patients to look at them and use them from their points of view so they can then come in prepped for appointments. It can be really helpful.
So we've discussed quite a lot of principles here today, but one of the things I hear that's really important is having the patient and their carers and whomever their advocates are, which could be anybody, including healthcare professionals, right in the centre. And then we have a network of colleagues around us which are supporting us whilst also supporting all of the assessment and the need of our patient or our client. But also helping us validate ourselves and share our thoughts. And the other piece that I've heard is the importance of whoever is primarily leading or facilitating the team, really needs to be in that space that allows everybody to be heard. And it's kind of all equal because everybody's opinions are important. And then you kind of reach a consensus over the different areas. And it may be, with exactly the same clinical scenario, it may be something for one person that takes them in that direction because it's the right time for them right now. It may go in a completely different direction for another person because it's the right time for them right now. But overall, when you take the holistic view, you kind of know when you're going to pull things off the shelf. And you've got all of the guidance and all of the people around you to be able to do that. I don't think that I could practice the way I've been able to practice over the last 25 years without the privilege of all of that infrastructure around me. And I truly believe that it's been that has made the care of the patients that I have been responsible for so incredibly successful for them and so rewarding for me. So I absolutely, MDTs are a given in terms of our structure, right? But sometimes you just need to sit back and reflect on what they're actually giving all of us and how they actually work. They can go wrong sometimes, and that's where we need to kind of rebuild the trust that you were talking about, reintegrate, both for colleagues as well as for patients. But you've all brought out some really beautiful principles. I'm going to finish off this section before we go to the Q&A with a question to all of you, one after the other. Let me just get the wording for this correct. And it's just a closing reflection. So if you could give one piece of advice to healthcare teams working with EDS and HSD patients, what would it be? So I'm going to start with Luke. Give Luke.
To summarize it in one word, and I think it's been said so well already, listen. Listen to your patients.
Yep.
Yeah. Yes, I'd say communicate. Teams and patients.
Yeah.
I think being aware, 99% of the healthcare professions are not aware of the condition, which means everything else, whatever you say, goes in the dustbin.
So learn, listen, communicate, learn.
I think it's just really important to remember that it's a long game, and it's an iterative process, and not to get frustrated if things don't go exactly right in the beginning, but just to recognize the importance of what we're trying to do and keep at it.
Thank you. Take it.
Yeah, I'm going to go a little bit out of bounds here, Alan. And
Go for it.
This is actually advice for the patients, because I think this is great advice for the care team, but I know there's so many patients in the room too. So I think synthesizing all of this, that yes, patients focused, patients being heard, is I think the message for patients, if you don't feel like you are central to this discussion, then you should say something. You know, this is pivotal to your health. And you should be confident to know that this is the purpose of your care, is for you to be heard. And if you don't feel like you're being heard, then you should.
I think patient education is going to be the thing that changes and shifts that siloedness in this country around the world. And then being online, social media is changing the environment. So for patients to be educated and to feel empowered, and or to remember they can take somebody with them to an appointment, they can have an advocate with them, that it is the long game. This is a long process. And so having that hope, but understanding you need a team behind you as a patient as well to get you through that long game is really important. But hope, power, encouragement, education, it's all powerful.
Thank you. And we've noticed from the kind of echo work that we do with our networks that having empathy and compassion are just critically important, and maintaining that empathy and compassion is critically important. And so one of the other reflections I have is, whilst we are all here for our patients and the people that care for them, we actually also have to be here for ourselves and our colleagues. So compassion, it is everywhere, and that's really, really important. Well, look, thank you very much, everybody. We have reached the end of gone past, because it's me and I'm terrible with timing, the end of our session together for this bit. But there is a Q&A now, and I can tell you there's only one question. So I think we can come back and have a bit more of a conversation, unless other people wish to ask us questions. But please, from the audience here and from those that are virtual, if there are any other questions you'd like to ask, just pop them into the Slido for us. But this question's come through in the last 10 minutes or so that we have. What can we do to encourage communication between team members when one hasn't actually established an MDT? So this is a situation where the network doesn't really exist, but you've still got to communicate between people. So maybe let me start with Claire. How do you try and establish communication with people that aren't really part of your MDT network?
So I tell patients that I'm available to their providers, and encourage them to reach out to me if they have questions. And I try to be responsive in as prompt a manner as possible. And on the other side, I ask them to send me notes from their providers, you know, so the people who are seeing them. And then if I have questions about that, then I try to reach out to those people. So to start establishing a network, a patient-specific network of the people who are caring for that one particular person, so that we're all in communication.
So in that situation, you become the kind of advocate. You're right at the center of everything. I want to just ask other members of the group, how often has it happened that you've offered your availability to anybody, email, phone call, knock on the door, don't mind, could be even down the corridor, and it never happens. What's your experience of that, Luke?
Certainly more than my fingers and toes. Look, I think as an allied health professional and someone who, rightly or not, often is that first port of call, or someone who, they've perhaps seen a couple of people who haven't believed or haven't taken them seriously. I've just taken to doing something that I call doing the dirty reps, picking up the phone, sending an email, writing a letter, often all three. Because I think, and I reckon the allied health professionals in the room could attest to this, we understand that the other people in the team, particularly medical specialists, are so incredibly busy. You're seeing so many people. I get the privilege of sitting down for 80 minutes with someone for an initial appointment, 50 minutes for a subsequent, and sometimes 30 minutes. And that's not a luxury that many medical health professionals will have, although I do know some fantastic ones who will take that time with people where necessary in this space. But I know that means that my time can be used for those tasks. And if that's going to be in the best interest of the patient, is going to get the boat going faster for them, then that's what we do.
Yeah. Dacre, what's been your experience of offering?
Yeah, it is kind of ironic just how you mentioned it, Alan, because sure, you can offer it to everyone, but the ones who reach out to me, I tend to see are not necessarily those who I would expect. And either before or after I've seen the patient, and maybe I'll reach out to them to try to get more background information on the patient, or after the fact. I know Maggie Buckley is somewhere here in the audience, but we had a really good ECHO program talking about patient advocates, patient care advocates, and care coordinators. It was a long flight over here, I apologize. But that's certainly an important role, and I think it's a growing role because there's a link there from the care team to the patient that's helping decipher some of this information, even if we don't have a specific channel of communication to GPs or primary care doctors. It's a very important role and growing.
There's actually a supplementary question from the audience here, which I think is a great one to bring in here. And how do we deal with colleagues who will refuse to work with us or with a patient? So we're reaching out to them and they refuse to get involved. It sounds like you may have had some experience. What are your thoughts?
It's working through the workshop that coming up on Sunday on this diagnostic process. We were having a discussion around the fact it's almost like the art of war. And preparing yourself to how do you meet somebody who wants to actually fight you and disbelieves both you, the patient, but also disbelieves you as a health professional to your face. So being that patient advocate, and we talked about this morning, we said, okay, well, you know what, in this situation, maybe we don't go down that particular specialist path. We go start fishing elsewhere. And it's a matter of that persistence until you know your networks and your healthcare teams and in and around our country now, which we're much better at now, but I suppose there's a strategy. Getting upset with somebody isn't going to work. Confronting someone head on isn't going to work. Numbers, stats, articles are definitely going to work. That's definitely influential. Doesn't necessarily mean they're going to come on board, but it means that you may have made, just that one more drop in the pond. That might just be the next shifting point. It can be really hard for patients, and as you said, compassion is really important. The invalidation over the years to get a diagnosis. Australia's 15 at this point in time. So having compassion with them and making sure they're okay during this process, because they are, they're receiving it more than you are. And be honest, over the years, developed a very thick skin. So it's that concept of, we're just in this for the long haul. And I think, like all of us here, we have our patients' backs, and our patients know they have our trust. So we will then keep persisting on their behalf if we need to, until we actually reach the answers we need to reach and get that team we need to get.
Yeah.
Can I ask you a question? This is a very, difficult thing for us to do. So, for example, if I see a patient, I think POTS is a predominant symptom. I talked to a lot of my cardiology colleagues, and a couple of them said, "Yeah, I understand. Yep, I can diagnose." but don't ask me to treat them. They said it's really hard. So,
Because all they want to do is write a script and then charge. They don't do the rehabilitation.
I don't think it's about charging. I mean, just being honest, I know some of them are, but I think, as you know, David was saying, that it's being tough is made it really hard, and I think that's where the teamwork makes it, you know, a bit more better, that you're sharing this love.
Yeah.
You know, if I can say that.
Yeah. Yeah. No, love.
And the passion.
And the passion. Yeah. I think bringing people in who are not familiar with that, who have been resistant to trying to support you and your patient is one of the really key things. So it's, whilst there might be resistance, you work your way through it. Sometimes you have to work your way around it. Sometimes you have to work your way over the top of it. But I found that a lot of people over time, when you bring them in and they feel that they actually can be of value and they are also supported, it just changes that relationship. You brought a really interesting point up, which is going to be the last main question that we'll ask today. And it's a really great question. It's around how you handle the financial impact of being a patient that is working their way through, you know, a multidisciplinary team, because there are so many different structures. Louise, maybe if I come to you thinking about the way in which the healthcare system is set up in Australia and the implications of multiple people in a team from a financial perspective for the patient.
Yeah, so it's really tricky. We've got a very old system that was set up to fund hospital medicine called Medicare. We've got a system that's set up to fund disability support, but not making people better, called the NDIS. And there's a big gap in the middle that I would describe as rehab, which is actually getting someone who's not acutely unwell in a hospital bed or dying because they've just been hit by a truck, but has a severe disability that is affecting their ability to work, to parent, to live, and is potentially reversible. So the NDIS will say, no, your condition's potentially reversible, which is kind of a good thing because that's hopeful, and in the right hands, there's probably quite a lot of gain to be made. But we don't have funding for community-based rehab.
Right.
So
I heard about this NDIS, and I was thinking with my smart wisdom of whether I could actually turn it into something, and I thought N stands for no, D stands for does, I stands for it, and S stands for service. So nobody does it service.
Yeah.
Is that, in the context of our community, is that correct? That works.
So we're kind of very lucky because allied health professionals who work under the NDIS framework can't help themselves but try and make the patient's gain function,
Right. Yeah.
which is efficient.
We try our best. We really do.
Which we try,
we
because they're not meant to improve.
Yeah.
So anyway, and then Medicare, there's ways of stacking up your appointments. So if you're on biannual appointments, you decide 1 year you're going to use the Medicare safety net, please register if you haven't. And you do every single thing in one single year, and you send your husband off to get his hernia done. So you hit the safety net really quickly.
Even if you didn't need it. just get him out of the house.
Grommets and
You get your teeth done, you make sure the children's eyes are all done, all braces are done, and you just get through that net.
And then you have a year of peace, and then you go.
So
But it's by calendar
we're
year.
not promoting fraud, we're just working out how to...
It doesn't say you can't stack your
influence the
long-term
system.
appointments into a certain time frame.
It's accessing care the best way you can.
And this is an international problem, right? I mean, it's everywhere. So think about the system in the United States. And you've talked about the economics of care before.
Oh, yeah, absolutely. It's something we're continuing to study through our practice, and we hope to be publishing these results soon, because I think that's a way you can visualize the impact of it. Even if we can avoid the hospitalizations and if we can avoid the emergency room visits, we still see there's a major, major impact. Not only money, but also time, the time the patients spend, visiting and taking time out of their work and all those other things that they're doing is crucial.
One of the things that strikes me is if you are establishing a business as a group of healthcare professionals and you integrate your team into that business, my experience has been that actually even with the money that does flow, it nowhere near covers the time, the expertise, the effort. And I put it to you as a question that 50% or more of all of your time and everything that you give to the care of your patients kind of comes for free because it comes from you guys and your service. Is that a fair assessment?
I think we're all in this space because we're passionate about this space, and we're in this space because we either have lived experience ourselves or familial experience. Well, I can speak from the people I know from my networks. So yes, look, some of it does happen on Saturday nights when other things should actually really be happening, or Sunday nights. But that's part of that's our mindset. We don't want easy, we want complex. We find the joy in the harder to solve, and let's help those people. We'll make a difference. And really change lives around and change families around, because as we know, you may be treating initially the 6 or 7-year-old who then brings along their sister, their cousin, their auntie gets pregnant, grandma had it, and then we find out uncle, and just it becomes it's so widespread. So yes, it's from our hearts that we give, but I think also that we get back, because this is an amazing patient population. After working through hospitals, in private practices, sports patients, I think patients in this area of needing rehab and disability give back so much. They're such an amazing bunch of patients. I love having my EDS connective tissue HSD patients. They're just amazing. And I try and sell that when I try and now to get other physios on board and say, this is the best patient population you can actually have.
And I think it's a really great place to close there. There is the compassion and the empathy right in front of you.
Yeah.
Thank you very much to the whole panel. That's the end of our session for today. And I'm going to invite Lara back up.